that's a federal PAC, like right here, PDAmerica.org. The issue side is people demanding action, and if you look at the handout that we printed up,
that's right there, I wrote it right.
yeah, it's got it right there at the top of under advocacy is people demanding action.org, and so that's where our issue teams reside in the organization, and I head up our healthcare issue team. So, so just a word or two about me. I'm a retired emergency room physician. I practiced here in Orange County for, it was 35 years altogether. 2 years before that up in the Central Valley where I did my training in Bakersfield. Weird place, but grew up here on the east side of LA, moved down to Orange County eventually to raise my family, start a family, raise my kids. So I worked for Kaiser for like 30 years out of that 35 years, and so I'm a pretty established Kaiser doc, and you know, Kaiser has kind of its good and bad side, or the good, the bad, and the ugly, which we can get into if you all want to. I'm happy to talk about that as well, but I've also been involved in politics as a political activist, basically, and in particular Democratic Party activist since my youth, when I actually got I jumped in and walked precincts. I remember for Eugene McCarthy, and had a big fight with my best friend who was for Bobby Kennedy, because you know, I said, well, you know, Bobby's a Bobby come lately and is not as strongly against the Vietnam War. So we had this fight, which kind of culminated with Bobby getting shot, unfortunately. So, that was kind of my introduction into the Democratic Party and kind of the clash of the titans, which included two 14-year-olds who were walking precincts in our neighborhood up in Monterey Park.
Hair down to here.
Yeah. Oh yeah. So so anyhow, I've been since then I've been a delegate to multiple national conventions at this point. Way many more, 10 times as many state conventions. I've been on the County Central Committee. I've been an officer for the party, and currently am on the County Central Committee, and also the Democratic Club president. So I think that's about as inside the party as you could get. Including I was a delegate for Bernie in 2016 in Philadelphia. So on the other hand, I'm also involved in a lot of community organizations that are nonpartisan. Like Orange County Peace Coalition and the Orange County Climate Action Group, and lots of groups that are nonpartisan, and they like to keep it that way mostly for tax purposes. Which I understand, I completely understand. I'm also a member and on the steering committee of Physicians for National Health Program, which is an excellent group that we'll talk about. That's advocating for single-payer Medicare for all system nationwide. I think, as such, being a medical person and a political person, it's kind of like a perfect storm, a harmonic convergence to be an advocate on what I think we need to do next for healthcare reform, and to, you know, approach some civility. I mean, actually become a civilized country like the other advanced countries in the world, and like Bernie calls them the major countries. I don't know what he means by that. Major countries of the world who have single-payer systems like Medicare for all. So I've been studying this for some time. You know, I'm an amateur. Henry over here is actually a pro. Even wrote, he has a doctorate in the subject, medical and healthcare systems. You know, so, and I've been collaborating with Henry now for some time, because we're both local and everything, and which is a great thing too, to talk about these things. So, so basically what I wanted to do, and I offer it any group that'll have me as a speaker, is to kind of explain the basics of Medicare for all. Because a lot of people, you know, the first thing they do to fight us is to generate confusion. You know, so that's what we have to do, is to fend off the BS, right? So it's like the Parkland students say, you know, to the NRA we call BS. So we have to say to the insurance, to big insurance and big pharma, we call BS. So we need to know what really is Medicare for all and what's not Medicare for all. And that's very important right now because we have a lot of Democrats who are beholden to big insurance, big pharma, you might call them, you know, establishment Democrats or conservatives, dinos, Democrats namely, basically still taking big bucks from these entities and therefore proposing things that are not, they're definitely not Medicare for all.
Dr. Bill, there's another category, I would call them scaredy Dems, who are would-be progressives, would-be supporters of Medicare for all,
yeah.
But they're afraid that the other side is going to make a big deal out of taking away private insurance choice.
And you know, frankly, I think they're it's a great point, Jonathan. They're actually linear thinking Democrats. They're thinking center right, center left, triangulation. You know, how am I going to be? You know, not too far, not too fringe. When actually, I think I always say we have a lot more in common with Trump voters than people think. I mean, we all have, you know, we have a family, friends, co-workers. We all need clean air, clean water. We want people to do well in general, excluding white supremacists here. So, you know, but, you know, we want our, we don't want to see people suffer for lack of certain basic human needs in general. And I think that's where right and left kind of meet around that. So that's more big tent thinking rather than that linear thinking. And a lot of people get into the, you know, what's practical in this political environment kind of thing, and they get in this trap of thinking linear, center right, center left, instead of thinking where do we have common ground. And where I would take issue with them is like in 2016 when the Democratic primary was decided and they were interviewing people on their driveway, you know, across America, and people were saying, well, I would have voted for Bernie, but he didn't make it into the runoff, or, you know, the finals. You know, they have all these other names for it. And, you know, so I'm voting for Trump, you know. So how does that happen? I mean, people thought that, you know, Bernie and Trump offered something that was very different, and that could get them out of, you know, what they perceived as the political mess that we're in. And that to me is not linear thinking anymore. That's something where we can actually find common ground. So I think healthcare is a prime example of that. You know, obviously the bigger threat to our existence even is global heating, you know, and the impending climate catastrophe. So we should all be paying attention to that. But, you know, in the top category, always on people's mind in political discussions nowadays, is healthcare. And that's because there's such glaring problems with it that need to be fixed. And, you know, 10 years ago, the Affordable Care Act was decided upon, and was rolled out within a few years after that. But 10 years ago now was when Joe Lieberman shut down the public option. That one guy, you know, talk about unitary executives. Joe Lieberman shut it down in 2009. So that's a decade ago. I personally was a fan of the public option then. I've changed my mind since then, and think it's no longer an alternative or some kind of intermediate stage in my mind. We'll talk about that too in a minute. But we still have a healthcare crisis. That's kind of the top there. If our goal is universal healthcare where all the people get all the care, that has to be the goal. Okay? So how do we make that happen? And that is the case all around the world except here. Well, really we have to eliminate waste, fraud, and abuse in our current non-system that we have. And that will make it affordable and accessible. But we have to eliminate the waste, fraud, and abuse. So what are the critical points? Right now, the crisis of healthcare is the fact that we don't have the best healthcare in the world, right? We rank 37 or thereabouts, you know, in some categories even worse. Maternal mortality now, where our rate of maternal mortality has doubled in the last year or two. So now women are dying much more often related to
to pregnancy, prenatal care, delivery, postnatal care, women are dying now as a result. That's even with the Affordable Care Act and rolling out Medicaid in states that did that, okay? So we're not doing well. We don't live as long, higher infant mortality, that's absolutely still the case. The US spends twice as much, and for that we get lousy health care compared to other countries around the world. As an index, you can think of the fact that for every 1 million who are uninsured, that results in about 1,000 preventable deaths per year. And the uninsurance rate in America is still about 10%. So it was higher, and then it got much lower. Now it's going back up again. So now it's about 10%, which means we have approximately 37 million people in the country, or 35 million people, which means 35,000 preventable deaths per year. And that's just due to the fact that people, they can't even get on a waiting list. So people say, oh, you have long wait times in Canada. Well, in America, you can't even get on the waiting list. So how you can tell who's waiting longer if you never could get on the waiting list, okay? But it's not just the uninsured, as we know, it's also the underinsured. So the concept of underinsurance, where you buy a healthcare plan and it doesn't pay for all of your healthcare needs. And that results in medical bankruptcy. So the number one cause of person bankruptcy in America is still medical costs. And that's a very significant number. In fact, 75% of the people who go bankrupt, I don't think they've actually surveyed people on the street who are living, on the streets, homeless people. It's considered to be a large number, a significant proportion of those people are there because of medical debt that they incur.
I think I read that it was Orange County's gone up to 8,000.
Just folks
homeless on the street.
Yeah. So when you look at the total number of people who declared bankruptcy because of medical costs, 75% of them had insurance. So that's just the underinsured, right? Their insurance didn't cover everything, to the point where they lost all their assets in that. Okay, so that's a travesty. A third of every healthcare dollar is lost. It's just goes up in smoke. It's actually it goes into kind of like intangible things like administrative costs and advertising, CEO pay, stuff like that. Basically, you can think of it going from your pocketbook into the Cayman Islands. Somebody is, somebody's offshoring that third of every healthcare dollar.
Plus fraud, $272 billion a year.
Pardon?
$272 billion a year worth of fraud.
Wow.
Of fraud, yeah.
Fraud.
So again, waste, fraud, and abuse, we lose a third of every healthcare dollar. I think it's Don Berwick in the movie Fix It, says his budget was like about $3 trillion, or not his budget, but what we spend is about $3 trillion. So
3.6 now.
3.6?
Yeah.
And what we lose then is, $1.2 trillion, are going basically into somebody's pocket, or literally into the Cayman Islands. Okay, so this is corporate welfare, or like Dr. King said, it's wealth for the rich and rugged individualism for the poor working class. Okay, so that's where the money's going. What we're talking about is capturing that third of every healthcare dollar, where it's not given away to these crooks, these modern day corporate robber barons. We're talking about recovering that money. So we're not looking for new money. We just want the money that we're already spending to actually go to healthcare instead of going into somebody's pocket. And so people say, well, it's pie in the sky to think of, Medicare for all. How are we going to afford it? The answer to that is we're already paying for it. We're just not getting what we're paying for. Okay, so that's what we're talking about doing. And I like to use Marie Callender's pie. When people say it's pie in the sky, I say, no, it's Marie Callender's pie. If you go to a pie shop and you buy a pie and you get home and you open the box and a third of your pie is gone, somebody's bite mark still in there. you'd be plenty pissed, right? So we ought to all be plenty pissed that we're not getting the services that we're paying for. And that's what we're talking about here. And just think about that. Once we recover that money, and it actually goes into healthcare, you know, we can hire more doctors, nurses, build more hospitals, clinics. It's an economic stimulus package, Medicare for all. When we recover that money, not spending anything more on healthcare than we currently do, we promote the economy. People say, oh, what's to keep people from moving here for healthcare? I'm like, fine, let them come. You know, it'll just stimulate the economy even more. It will create jobs and create prosperity by doing this, by recovering that money and investing it into actual healthcare for people.
Would you say that we're 37th primarily because of lack of access?
It's lack of access, but it's actually negative stimulus. Like people, you know, with things like co-pays, deductibles, people make wrong decisions for their medical care based on their pocketbook. So, you know, like in my setting, in the emergency room, people would complain to me that they had to pay a copay of $100 to be seen in the emergency room. You know, and they'd say, oh, well, okay, so I'm not having a heart attack. Do I still have to pay the $100? You know, and I'd say, let's bring the financial counselor in here. But if you think about it, who would want folks to sit at home and wait and see if they're having, you know, heartburn or a heart attack? They ought to just come on in. We should be paying them $100 so that they came in and we figured out what's going on with them. Okay? That's a business model that promotes, you know, more business kind of thing. Whereas somebody's sitting at home, toughing it out, deciding, oh, should I call 911? What's the ambulance going to cost me? You know, and I'm going to stick this bill with my kids if something happens to me. That shuts down people right away. Okay, more than a fear of a needle or a knife or something like that. It's those kind of negative financial disincentives. I guess that's a double negative, but they're the financial disincentives really what's causing it. So like in Canada, like Henry's from Canada, people don't have to do that. They don't struggle over that. They say, I'm having some chest pain, I'm not sure what it is, I'll go get it checked. There is no, you know, computation that goes on in your mind. Other than, what else do I have going on in my life? Do I have time for this? You know, I'm not going to lose sleep because I went in for, you know, a stubbed toe or something. Okay? And actually people are very good, I call that self-triage. People can decide if they, you know, what level of kind of medical support that they need. And I think that goes on in Canada and other universal healthcare countries where people figure that stuff out. So that's why people are falling through the cracks in this country, you know, and are giving us those poor outcomes. It's, you know, doctors get frustrated. I mean, I can tell you, people refuse tests. You know, I would see them and, you know, not know if they had appendicitis or not. You know, a friend of mine, her daughter died. She went to an emergency room in Las Vegas. They told her it was going to cost her $3,000 to get an ultrasound to see if she had a blood clot in her leg. And she walked away from that and then died. You know, so that's what's going on in America. It's a travesty, really.
People see their doctors in the United States about 3.5 times a year. In Canada, it's 7 to 8 times a year. In Japan, 13 times a year. So you've got this wide disparity in where the United States is the outlier in almost every healthcare statistics, both financially and for health reasons.
Right. So we're losing all the benefit of prevention as well, right? The ounce of prevention is found a cure. So people won't go see the doctor, you know, thinking, well, it costs too much, you know. Again, they have other reasons to delay or procrastinate. It's not fun to go to the doctor, not, you know, sexy thing to do, you know, like hanging out in Starbucks, you know, or something. So, you know, or coming to Denny's. So, you know, but like in Japan, for example, it's part of their culture. I mean, the old people go and see their doctor once a week, you know, and you're connected that way. And especially if you have ongoing medical problems,
you're gonna have ongoing questions and needs that way. So they're well connected, you know, it's part of their culture, and that's why they're doing so well. We've kind of rationed ourselves down, you know, thanks to the insurance companies especially, and Big Pharma rationing down, you know, medication. We'll get into.
That's what I was just gonna ask. Are you going now into
Yeah.
drug costs?
Yeah. So just two more stats before we do that. One is that this is well-established science. Okay, so we all believe in science, right?
Yes.
Climate science, healthcare science. Many studies have been done over and over again. Independent analysts, academic analysts, even the partisan analysts all show that this kind of system will save money and deliver better care, like expand benefits so that people get more care. Like, for example, dental care, okay? We need dental care. Canadians need dental care. But, you know, Alan Grayson came up with a congressional bill he called Seniors Have Eyes, Ears, and Teeth, because they're not covered in Medicare. You know, dental, vision, and hearing are not covered. Of course they need to be covered. So we're the richest nation in the world. We can cover.
Sorry, I have to go.
You have to go.
Sorry, yeah, I said I believe in 5:15.
She has
I'm
a
so
dinner.
sorry.
She has a dinner appointment with a very, very elderly friend who depends
Okay.
on her for comfort.
My contact information is up here, so feel free to ask questions. You're welcome. So the potential for saving is huge, and it's as an index, for every million people in the population, we could be saving $1 billion per year. Okay, and that includes at any locality. So, you know, how many people in the city of, did you say it's San Juan or
Campus Drive.
what's the population size?
37,000.
37,000 people, so you could save $37 million a year for the city of San Juan County. Okay, if we went to a single payer Medicare for all. It's even better than that because you could design the system to exempt the city as a public agency. So, for example, you know, businesses may be taxed to assume some of the costs. Like right now, most businesses make a contribution for their employee health, especially public agencies, right? So it'd be good to find out from the city what their annual budget is for public health. In California, where we tried to do this last time, that proposal actually exempted all public agencies from any contribution into the health system. So all the city would have to pay is the usual to the feds, which is, you know, Medicare and Medicaid and Social Security, is, you know, taken out of your payroll tax. But this one didn't have a payroll tax. It had a business gross receipts tax. And cities don't take in gross receipts. School districts are very labor intensive, right? School districts, teachers, janitors, all the staff that you need for school districts, that's very labor intensive. They have a very high proportion, it could be as much as 50% of their annual budget is actually employee health. And you can exempt school districts, cities, you know, counties, and that's what we tried to do in the last iteration for California. That was blocked by the unitary executive of the Assembly, Speaker Anthony Rendon, who gets a lot of money from big insurance and big pharma. It's not a surprise to me that he might block. What he'll say is that, you know, we aren't ready for it yet, right? Meaning the public's not smart enough to know that's what he's up to, or something. Bottom line is that it polls very well. Okay, so the polling data for Medicare for All is right now it's 70% favorable across the country. 85% of Democrats like the idea, 52% of Republicans like the idea. I mean, you can imagine in California those numbers are much higher. You know, it's probably 90 to 95% of Democrats like the idea of Medicare for All. So the question becomes, what do they like about it? Because when you parse it out, you ask people, okay, if you're willing to give up your private insurance, you're willing to have your taxes, you know, then that kind of loses the enthusiasm behind it. But when you think about it, this is the way I like to think about it. And again, it's kind of to put up the, you know, we call the S thing, okay? When you frame a question like that, you know, the question becomes, what parts of the question is that people are responding the most? And what I'm thinking nowadays is that
It's two things, basically. It's Medicare and it's for all. Okay? Medicare, which people know and like, a lot of us have it, and we're fine with it, you know, the way it is, or could be better, needs tweaks, like eyes, ears, and teeth, you know? And we could get rid of the co-pays and the supplementals and all that stuff, like the old-fashioned Medicare before Bush and the Republicans added parts A, B, C, and D. Okay, and that's what we're talking about. We're returning to traditional Medicare, which people know a lot. And then it's for all. Okay, so we need it to be for all, meaning for everybody. So that means that, you know, it's not means tested. It's not if you don't make a certain amount of money, you're going to have a subsidy of some kind, or, you know, is it going to be like Medicaid, where, you know, or even the exchanges, where you're going to have a bronze plan or a silver plan. Now, I have to say we all should be on the green plan, because everybody's gallbladder is green. When you open up a belly and look inside, there's this funny little punching bag under your liver. That's green, and it's called your gallbladder. And we've all got one, for the most part. And some of us had to have it taken out. And good riddance when you need it taken out. Doesn't do you any good after that. So, we all have the green plan, a lot like a traffic signal. We're all on the red, yellow, and green plan on the traffic signal. And, you know, rich people don't get to go through those. A red light, right? So that it needs to be universal that way. I mean, if you think about a traffic intersection, that's crowd control, so we don't all run into each other. It's really a public health measure, so we don't run into each other. So this is a public health measure that means that we can all be as well as we can, especially in nations that can afford it, and we can. We're the richest country in the world. So they tell us, okay? We just need to redistribute the wealth a little bit. Okay, so the essentials of Medicare for all, in order for it to be really Medicare, the expanded and improved Medicare that we want, and to be for all, we by necessity have to eliminate waste, fraud, and abuse, okay? So I'm just gonna go over kind of the top offenders. In waste, the top offender, there's no doubt about it, and everybody here would agree, and I'm sure anyone you ask, okay? The biggest waste in healthcare right now is insurance. It's private insurance, okay? And that's because there's so many of them, and there's all these networks and, you know, all this stuff. You don't know what's in the fine print of your policy. You know, you don't know if you're gonna get a surprise bill or all that stuff, because it's so darn complicated, you know? And we need to simplify and standardize our healthcare in America, you know, like they've done everywhere else around the world. And Henry has these great graphics that he worked up that kind of shows the complexity.
Oh, dear God.
Yes. So, you want to explain those?
Sure. So this is a partial adjudication process in the United States. We've got a family here trying to get adjudicated for the health care, and they go to PPOs, ACOs, or HMOs, and everybody's in some different program. There's about 4,000 carriers in the United States, which means that there's 4,000 of these different adjudication processes that go on like this. But this is just the top. Can you imagine like 6 or 7 other sheets like that sitting underneath? They're all connected, you know, somehow. There's 100,000 rules that apply to any single claim. And the reason we have to have so many administrators in the system is because any successful business these days is based on algorithms. If you look at Amazon, Uber, it's a proprietary algorithm that makes those things successful. Everything in our phone, the apps, everything that we do now is based on algorithms. Algorithms depend on sameness to work, and sameness. There's nothing same or sane in that. So every time you go to one of these little boxes, the adjudication may get stopped, and then it needs to be brought up by a real person, and it needs to be brought along to the next process.
Can I just interject there?
Yeah.
So what this means in practical terms is that doctors, hospitals, clinics, technology institutions of all kinds, diagnostics, have to work with these, in these adjudication processes with the people who are ultimately going to pay the claim, right? So whatever insurance company that is, and that means that doctors, hospitals, clinics have to hire this tremendous amount of staff whose only job is doing that, is dealing with this morass of other institutions in the adjudication process. And that means they're not delivering care to people, they're just settling the billing type thing. It's incredibly complicated and inefficient. And then that is compared to, like, say, the Canadian model.
This is the Canadian model for the same thing. And everybody is a member of the same comprehensive plan. Everybody's got the same health care. There's only one plan, and it only requires a computer at the clinic and a computer at the payer. And the only thing that can happen is if a claim gets kicked out, 95% of claims are paid 95 to 98% of claims are paid upon submission. And if it gets kicked out, it has to go through this little process here. But most of the time it's just like zip, 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 and then back here, and the health record is held up here. It runs on the same system. Every province has the same system. They may have different systems, but if two provinces need to talk to each other, they can, because they can talk across provinces in Canada. But this is the simplicity of it. And any doctor will tell you that it's accurate. So the billing cycle and the payment cycle for a doctor is every 15 days. And doctors get paid, 98 to 100% of what they bill every 15 days, depending on what specialty you're in. But the patient never sees paperwork. They never get an EOB. They never get anything other than their medical chart if they ask for it. So it's very simple.
So let me kind of put some icing on that cake too, and just say that this results in an efficient process to the tune of 1 to 2% administrative costs. Okay, the entire healthcare dollar, we're talking about 1 to 2% of administrative costs. The other one results in, conservative estimates say 20 to 30. I think it's more like 40 to 50% administrative costs. Okay, so that's what we're talking about here. If you know how people like to say we should run the government like a business. Which business model would you prefer? Okay, the 30% overhead or the 2% overhead? Actually, 2% is a little high. I think it's 1.5%. The VA operates at 1%, which is even more streamlined that way. Okay, so incredible waste and inefficiency. And there's all these bad jobs in there. Okay, so people always say, what about those jobs, all those people? Those are bad jobs, but they can be really, really easily retooled, frankly, into jobs where they actually promote and help people get health care instead of redlining and denying people health care like they're employed to do by insurance companies.
Yeah, I like to say that we can train them for honest, productive work like sex trafficking and smuggling drugs, bribing. But,
I'm not going to agree with you on that.
Right. But look, serious question though. The incentives of all of these little minion people who are working the system is what on the insurance side and what on the physician side?
Skimming off the top. And it's
denying
profitization. So when
medical costs.
Yes, when the Republicans, instituted parts A, B, C, and D of Medicare, and the supplementals and co-pays and the pharma donut hole, it was profitization. And, if Dr. King were alive today, he would say this is immoral because it's taking resources out of the system and putting it into somebody's pocket when there's a condition in human need. It's just pure and simple profitization. So, so let me go to the next most egregious part of this, messed up system that we have. I was going to use the F-bomb. Anyhow, so I'm being recorded. Live stream. You can
Live stream.
Who knows? There may be kids watching this. Okay, so the next most egregious thing we can go waste, fraud, abuse, but let me go to abuse, okay? Because these people now are really, corporate bad guys that everybody would agree, and that's big pharma. Okay, so the next thing we need to do besides eliminating the waste is to go after the egregious, racketeers in this industry, and that's big pharma. And big pharma, everyone should realize, no longer has a model of a business model that involves cost of production and cost of distribution. That's what most business models are, right? What are your costs of production, distribution, and then, making a little bit of money on top of that. Big Pharma has thrown that out altogether. It's no longer based on that. And what their business model is mafia. It's extortion. It's what's this drug worth to you? How much is this drug worth to you? That your child has severe allergies and is going to need an EpiPen at some point, in all likelihood. And you ought to have not just one EpiPen, you need one for the car, one for the boat, one for camp, one for school, and all of that, but they only have a certain half-life. Okay, so let me break that down for just 2 minutes, okay? What's an EpiPen? You know?
Yeah, it's for allergy. It's like an emergency. I'm
Allergy,
gonna die.
Like a bee sting.
Yeah.
A bee stinging you is an injection of a toxin, and people can have immediate life-threatening reaction. The only thing you can do in response, oftentimes, is another injection of epinephrine. The old name for that is adrenaline. Okay, been around forever. Adrenaline. I mean, I think like I was saying the other day, I think it's like Sir Arthur Conan Doyle wrote that into episodes of Sherlock Holmes. You get a shot of adrenaline, and when somebody's on death's doorstep, it can make them alive again, right? Where do we get adrenaline? Where did they get it, 100 years ago, 150 years ago? Where does it come from? Adrenal glands of animals, probably, beef, chicken, pork, porcine, extracts, right, from animals. So it's the adrenal glands produce adrenaline, which is epinephrine. Guess what? It still is. That's still where we get it. I mean, you may have genetic engineered, bacteria that they can produce it in vats. I don't know, but still, that's a basic ingredient. Okay, epinephrine is a generic, naturally occurring compound. Okay, what do you think that ought to cost?
5 cents.
5 cents. I'll give them 25 cents per dose. After you, extract it, purify it, and then package it and ready to distribute it. And on top of that, maybe a little bit more, okay? So that's the ingredient. Now, one thing I mentioned this too, is that you actually have planned obsolescence built in because it's a liquid. And liquid drugs don't have as long a shelf life, or what we call a half-life in the disease. So when a drug expires, a liquid drug, even if you keep it in the refrigerator, which most people don't, it's in their car or their boat or something for their kid.
By necessity.
It'll expire in like 3 months. So you're gonna buy 4 of these a year, per dose. So if you have to have 2 or 3 of these, one for the kid's school or otherwise, that's a lot of these things, okay? So it has planned obsolescence built in. You're gonna need more of these things. And, there's no way around that as far as anyone knows. Now, if it was 25 cents instead of the going price, that could be affordable, okay? To have that many of them, be buying them over and over again. The other part of an EpiPen is the pen. Now, what's the pen do?
It's a delivery system.
It's a delivery system. It's a syringe, basically. It's a spring-loaded syringe. So all you have to do is touch it and it injects, okay? Does that seem necessary?
Yeah.
Not to me. I'll tell you why. Okay? Because we give, in emergency, we'll actually draw up the epinephrine, inject it ourselves. We don't need any spring loaded. Now, obviously, we're fairly skilled at that. But I'll give you another example, the battlefield. Okay? Every World War II movie you ever saw had somebody giving someone a shot of morphine in the field. What was that? Yeah, a smack face. What were they doing?
Injecting.
It was a little tiny syringe that had some morphine in there, and they would push the plunger at the same time as they, tapped it on your skin.
So why do you need a spring-loaded one? You could just have a preloaded one. It could be like the kind that they used, you know, in the field. So we've been sold, you know, like Donald Trump's hair. You know, it's that substantial a need for this preloaded, fancy, you know, I think it's bright yellow packaging, you know, all this stuff. It's nonsense. But let's say you let them have that, okay? What do you think that little device should cost? I mean, what does it cost them to make it? You know, I'm going to give them $1.
Yeah?
Let's give them $1 for this fancy spring-loaded device that some genius came up with and sold to everybody like Donald Trump's hair. You know, that's a good thing for us somehow, okay? So frankly, you ought to go this route, you know, at this point, as far as I'm concerned. But anyhow, let's give them $1, you know, for one of those units, okay? That's the cost of production, okay? Cost of distribution, plus some profit on top of it. I'll give them $5 or $10. I'll give them $10 per dose. Do you know what they cost?
100.
700?
700 for 2. So it's $350 per unit, okay? And they make you buy 2, like it's Costco or something where you can't leave the store without buying, you know, more than one of everything. So they make you buy 2, $700 a piece. And you're going to need those 3 or 4 times a year because of that half-life problem. Okay? At $10, I think none of us would have a problem with that. We have ourselves or a family member with severe allergies. We could spend $40 a year on it. But right now, this is highway robbery. We just have our wallets open, these guys, and they're extracting that. If you look at these antibiotics, that sometimes they can be kind of, you know, rarely used drugs, or what they call orphan drugs, you know, where there isn't a huge need for it. Like there were these, there's a drug used for an infection that's for people with compromised immune systems, like HIV. Okay, so you know the bad guy on that one. The drug, the pharma guy. Martin Shkreli, right? Remember that name? Martin Shkreli. That's what he was trying to exploit, was the fact that these poor people who are afflicted by this are going to pay, you know, they're going to give away their house, whatever it takes to get the medication to stay alive. So that's what we're talking about. It's extortion, you know. Those drugs do not cost that much to make. And the old pharma, you know, we call BS excuse of this being research and development, that's BS. It's not research and development. Research and development mostly goes on in public institutions across the country, meaning under public grants. That's our money, okay, for the research that develops these things, or it goes on in other countries. So it has nothing at all to do with the drug companies who are claiming that they need that kind of money to promote those drugs.
In Canada, every drug company, even for the brand name drugs, are compelled to give the Canadian Drug Agency, they have to give them their factory gate price. And that's the cost of manufacturing with all of the marketing and everything taken out.
Right.
And Canada gives them, and they negotiate, because it's the biggest business in the country. So they negotiate as a country for those drugs, and then the same price in every single province.
Which brings us actually to the third thing here mentioned, which is fraud. Okay, so pharma is not the only one guilty of that kind of fraudulent, behind-the-scenes negotiation for drug prices. Obviously, hospitals are too, but especially insurance companies. And what they charge you for, you know, the same service from one institution to the next, you know, are different charges. That's all going on behind closed doors. That's what private, in private insurance, that's what private means. It means it's behind closed doors negotiated, where none of us can see how they actually arrived at those things. This movie, by the way, I forgot to mention it right at the beginning, but Fix It Healthcare. You haven't seen it? So you should. You can watch it online. Just put in Fix It Healthcare in a web search. It's a wonderful movie. It was produced by a business owner, kind of a semi-rural area in western Pennsylvania, I think around Pittsburgh. So
kind of semi-rural, but he has a company of about 150 employees. He figured out that if we went to Medicare for All system, his company would save a ton of money. And so he thought everyone should know about this, you know, once he looked at these kind of things that we're talking about right now. So it's a terrific movie. It plays to people who are so-called fiscal conservatives. We know Republicans really are not. And, you know, and most Democrats, especially establishment Democrats, are not either. But progressives certainly are. Fiscal conservatives, because we want the money actually to be used for the intended purpose, which is to get health care to people. But there's a wonderful scene in there where a fellow named Don Berwick, who was the head of the Center for Medicare and Medicaid Services under President Obama, he said, I guarantee you, you have no idea how they arrived at the prices that they arrive at. He said, I don't even know. And here I was the head of the Center of Medicare and Medicaid Services for the entire country. So it's all done behind closed doors, which means that it's fraudulent. Okay, we have to assume there's nobody looking after this. There's insufficient oversight. They're arriving at these numbers by their own means, you know, based on market share dynamics and stuff that may not have anything to do with the welfare of the people in this country. And that's fraud. That means that people will end up dying because of some deal that was made behind closed doors with, you know, that didn't have their interests in mind at heart.
Back a second into your major costs section of this talk a few minutes ago. Clinical trials are a major cost, aren't they? And who pays for them generally?
It falls in the same description as research in general, which is that it's the clinical trials are usually done by institutions who are, you know, who are testing these drugs, meaning teaching hospitals, university centers.
The cost is borne by the pharma manufacturing company.
A lot of the funding is coming from foundations and the public.
Right.
Yeah.
Right.
And in fact, I think the statistic is about only 20% comes from the drug company, although they get to parse the information. The information only goes to them. The university doesn't even own the information.
Yeah. Okay, so that's the waste, fraud, and abuse. So what we need to realize, okay, is this statement number 4 under Essential Medicare for All, which is that providers and hospitals will remain privately managed, but will have public. The public will be free to choose which doctor. There will be no more network type things. You'll have actually more consumer power this way because you can choose based on the reputation of the institution or that particular provider, as opposed to something your employer set up for you. You know, that was a deal made with an insurance company behind closed doors. They'll have standardized reimbursement for doctors and hospitals at Medicare rates, not Medicaid rates. So everyone says, well, what about, you know, doctors who refuse to take Medicaid or Medi-Cal in California, right? Because it doesn't pay as well. But they don't refuse Medicare unless you're like some, you know, one doctor I debated once who would see, she was a female doctor, would see only women with breast cancer for cash at Hoag Hospital. So, you know, if you're that kind of doctor, I mean, you know, for cash, sure, you can do anything with cash, right? So we're not talking about that kind of thing. We're talking about, you know, will Hoag Hospital see people with Medicare? Absolutely. Will Kaiser see people with Medicare for all? Absolutely. You know, all of these systems are set up to do that right now. And so none of that would change at all. And it's not Medicaid that either pays doctors and hospitals too little or provides too little in the way of benefits. Okay? So Medicaid has, or Medi-Cal would have some restricted access to treatment. So that gets it into our next category right there, which is what is not Medicare for all. Or you might call it Medicare for some. Or you might call it Medicaid for all. So like we just said, we can't do Medicaid for all because it's still inadequate. And people will still die and fall through the cracks, and doctors will refuse it, and, you know, and set up practices for cash or go to a civilized country where it's paid like Medicare for all. Okay, so we don't want Medicaid for all, and we don't want Medicare for some. And when you look at things like co-pays, deductibles, supplementals, or even buy-ins, the public option, that's really what we're talking about at that point. It's still Medicare for some, not Medicare for all. So you may have more people, if you bought in to Medicare, they're on the Medicare plan, and they may have more benefits that way than what they had before, but it's still that select group that could afford it. And that's not going to be everybody that you know or I know, that's for sure. You know, among normal people, okay, we're still going to know people who fell through the cracks, end up in emergency, can't afford. And that's kind of what the whole experience with the Affordable Care Act, you know, that was based on the Massachusetts model, right? Romney Care. Obamacare was based on Romney Care, which came from Nixon and the Heritage Foundation, which was, you know, the mandate made everybody buy insurance, right? And that's what's the experience was that, okay, you can tell everyone they have to, but oftentimes, you know, or all the time, not everybody will buy it. They still won't buy it. And whether they're fined or, you know, or some other way, there's still a significant percentage of people who end up without insurance. And that's certainly the case now. We can say we've had the Affordable Care Act now for 10 years, and there's still a significant number of people with no insurance at all. Okay, so that's the problem. I might throw in also the public option, and the reason I'm no longer a fan is Henry's scheme right there, okay? Because you're taking that scheme, that mess, and you're adding a whole other layer of mess to it, okay? So that did nothing to eliminate that, you know, all that mess. And if we're gonna wait, what, another decade for a market dynamic of some kind to you know, to get rid of that ain't gonna happen. It's not gonna, it's too little too late. It might have worked 10 years ago. We're way past that at this point, and we're much smarter about it now.
And what we know about the public option is the insurance companies will always find a way to write themselves in.
That's right.
Yeah.
It's risk pool. So that means they will they'll cherry pick, they'll change their risk pool so it's more favorable, you know, and that kind of thing. The Affordable Care Act outlawed exclusion based on pre-existing condition, right? Mm-hmm. Wrong. Because they can still charge whatever they want for that policy, okay? So they can just make it unaffordable for those people who have this pre-existing. They can't tell you they don't have a policy, but they can charge you whatever they want, okay? There's this nasty term called the medical loss ratio. I think I put that in the second section under eliminate waste. Medical loss ratio is what an insurance company considers a loss when they have to pay out a claim for you. That's a loss to them, you know, paying your claim, right? So the Affordable Care Act actually mandated the medical loss ratio down to 15%. Well, Switzerland and some other countries have it at 4%, okay, which means 96% of your healthcare dollar in Switzerland goes to your healthcare, and only 4% can go to that insurance company. That's in this country, it's been mandated at 15%. You think they're following that? Not at all. We have no enforcement, no oversight, you know, so insurance companies likely have violated that part of the Affordable Care Act. You know, as far as I'm concerned, I'd like to see proof of that. But if somebody wanted to come up and say to me, we're going to leave private insurance in, I'd say, fine, what's your MLR going to be? And if it's not in single digits, if it's not 2%, 4%, 6%, I'm going to say I call BS, because that system at 15% even is not going to work. Okay, we can't afford that.
Is the theory of the public option that it's in lieu of private insurance companies and it's a buy-in to the Medicare system? Is that the idea?
Well, basically it is. I mean, you're going to there'll be means testing, there'll have to be ways that you would qualify to have it. Okay, is everybody going to jump on right away? No, not necessarily. But
so why is this still involved if somebody opts to buy into Medicare?
Because there's going to be people who say, well, no, I'm going to keep my private insurance. I don't need to buy into Medicare because my union gave me a good plan or something. The problem with
Well,
most
it's not
people,
the same people. They're different sets of people. some stick with their private insurance and others buy into Medicare. So this is still applies to the group that wants to stay with their private insurance, right?
Yes, and it's still creating that incredible inefficiency, and they're gaming the system to the point where it's gonna cost the government more money. I mean, we all understood that back 10 years ago. We understood that the insurance companies would likely still, profit and make it more expensive to have the government plan. And we can't afford to have the government plan more expensive than it is already. In fact, we know how to make it cheaper.
Because they'd be skimming the cream, the private insurers would be skimming the healthy and making the Medicare pool
Right.
more sick,
Right.
more costly.
And so you're adding another layer of complexity to an already incredibly complex system. That would be my argument against public option at this point. I've just come to understand.
Would you say it's fair to say that those who are covered by private insurance are divided into two groups? One who love their private insurance and the other who've tried to use it?
Exactly. In fact, Barack Obama said that. He said 75% of people like the plan they have. So I'm not going to take that away from them. The problem is only 25% of people need it at any particular time. So, so that's very cynical, that view. That's a politically cynical view. I love Barack Obama. I thought he gave great speeches, inspired a lot of people. But that's a really cynical political view, to just discard that 25% of people who are having a tough time because they actually got sick. So we can't do that anymore. We're not going to settle for that anymore. And so, yeah, I like the way
Here's another one.
Yeah.
I think that when people get sick, they should be allowed to go to their insurance broker for health care.
Yeah, that's going to happen.
Or to their employer, their boss.
Yeah, walk into Allstate or someplace, frankly, I think insurance is for, should be, in my opinion, should be for rare occasions. I mean, we all have car insurance. We think it's a good idea. How often do you get into a car accident? Some people never. In their entire career of driving, never get in an accident. Earthquake, fire, fine. Healthcare is something you should have every day. Or once a week if you're an old person, you go in and see the doctor. That's not earthquake. That's not fire or flood. That's that's something.
That's life.
That's life.
It doesn't matter what country you're in. You still have the like the 80-20 rule. You have you have 20% of the people using 80% of the system. You have 5% of the people using 50% of the system.
Sure.
And that doesn't change from whatever country you go to.
Right.
So really, most of the people are healthy most of the time.
Yeah.
Well, that brings up a good point here, which is this other movie, which has been around longer, and frankly, it's a classic now too. It's called The Healthcare Movie. So you just put in healthcare movie into a web search. It's a beautiful documentary on the differences between American and Canadian healthcare, and how Canadians value their healthcare so much. I mean, a politician couldn't, that's the last thing they could do, is try to take away healthcare from people in Canada, and it's been the case. And it tells the story of Tommy Douglas. You guys know who Tommy? I know Henry knows. Tommy Douglas is one of the most revered, perhaps the most revered person in Canada, political history. Greatest Canadian ever, because he's the one that most people credit for getting Medicare for all in Canada. So when we got Medicare for seniors in the mid-60s, Tommy Douglas got it for Canada for the entire country. Okay, and the way he did that was a model I think that we should emulate, which is he was a prairie preacher, in Saskatchewan, right? Prairie state, mid-country. And during the Depression years, he saw that people couldn't afford to get health care, would die because they couldn't afford to see a doctor.
Happened to my grandfather. My grandfather froze his legs, he lost his legs, and he died of infection in Saskatchewan because they didn't have health care.
Right.
Yeah.
So he said that's not right. We as a country can do better than that, or we as a state or province in Saskatchewan he went farmhouse to farmhouse convincing people that, you know, that they should use their resources collectively to take care of everyone's health. I mean, what a concept, right? So it takes a village, or we all do better when we all do better, was the idea, right? And that then, you know, was passed in Saskatchewan. He became the premier of that province, which is like the governor of one of our states. So became the governor, and it spread across, you know, like they say, like a prairie fire, spread across the entire country of Canada. So this movie tells that story in pretty encapsulated form. And actually, the whole movie is narrated by his famous grandson, the actor Kiefer Sutherland. Mm-hmm. Yeah, so you know, Donald Sutherland is Canadian, and he married Tommy Douglas's daughter, Shirley Douglas, who's very much an advocate for healthcare in Canada. So, so she got her son Kiefer to narrate the film. And there's a very dramatic conclusion where he talks about.
By the way, he was the premier of Saskatchewan, and he was labeled a communist by the medical industrial complex.
Sure.
But he had 17 budget surpluses in a row, and no other politician, American or Canadian in North America, has ever had the success of growth that he had. And of course, he credited Medicare with a large part of that. People were happy and healthy.
Yeah.
So we need to wrap up because we're 10 minutes.
So I would just say, and by way of wrapping up, and maybe we can cover your question right after that, Jonathan. Is the last sections here is on the handout was Medicare for all working parts. I think it could be, you know, just that simple, like Henry's diagram. A medical board, a trust fund, Medicare care facilitators, like I said, those people who currently work in the insurance industry. I like these
companies. Companies. It's not an industry.
Yeah, industries make things. So unfortunately, health insurance is not a product, frankly, in my opinion. But anyhow, so that's the basic elements of what's needed for it, and it's incredibly basic, incredibly simple compared to the mess we have. These are excellent resources down here at the bottom, the advocacy groups, including Physicians for National Health Program I mentioned. They're actually MD PhDs originated from Harvard Medical School of Public Health. So we're talking about science here. So a really good place to get data, graphs, all of that stuff is PNHP.org. The National Nurses United, who are champions now and forever for healthcare. Our group. Now we're doing Medicare for All resolutions also. I would love to bring one of these to the Dana Point City Council or San Juan Capistrano. San Juan, why do I keep thinking Dana Point? Because we were talking about
I went down to Harbor this morning for breakfast.
you know, to anywhere. I've been working with Dr. Jose Moreno in Anaheim, and recently I had a discussion with Jose Solario, who's on the council in Santa
Should reach
Ana.
out to Deborah Lewis for Dana Point. She was just at our meeting 2 months back.
Yeah,
She's a
yeah.
Democrat.
And sure, the Republican majorities in these councils are not going to vote for it, but it's worth presenting to them. And we even, Henry and I wrote up a like a template testimony that you could give at your council meeting. We have a 90-second version and a 3-minute version for public testimony too as well. And that's under Medicare for All resolutions. So if you have any interest in that, go to that website, especially under toolkits. So, Jonathan.
Just real quickly back to our movie review section.